a colleague and I, representing the Not 62 Steering Committee, spent the first part of this week in New Orleans. For me, it was the first time at the a convening of the Community Culture of Health Prize winners um, that Robert Wood Johnson has. The Bronx was a Culture of Health Prize winner either 2014 or 2015. So we got to go and be part of this larger effort and celebration as they celebrated the 2024 winners. It was, to say the least, an experience that I will not soon forget, hearing what the 9 award winners from across the country are doing, how they're leaning into their work to dismantle health inequities, health disparities, and to push forward despite all the odds to have their communities get the opportunities to live their healthiest and best lives. It was a bittersweet experience because Robert Wood Johnson, after having done this phenomenal work, celebrating communities, working with the University of Wisconsin to share with communities their data on where they're doing well, where they're not doing well, and to offer technical assistance, insights, etc. That actually, Robert Wood Johnson, this is the last year that they're doing the Culture of Health Prize, and the last year, 2025, that we will have that report. It is distressing to know that this is coming to an end, especially at this time when there's so many challenges that we face coming out of the national politics and the new administration. But that being said, I am going to have Michael talk to us about the 2025 report. And hopefully, as we listen to Michael, despite the fact that Robert Wood Johnson is sunsetting this initiative, let's keep in the I'm not even say the back of our minds, in the forefront of our minds, how we can use what Michael will share with us, how we can use this to improve the health of the Bronx, and what we need to do as we think of the future. So with that, I'm going to invite Michael to come and talk to us. Michael.
Well, thank you for that introduction, Charmaine. And I'll just note that this is one of my favorite presentations that we give every year, because the work that you all do is just so inspiring, and the ways that you have mobilized and taken action and worked together has really been just a model for how we create change within communities. So thank you for that. I'll note that I cannot see chat right now, or actually people's faces. So please come off mute if you have kind of any questions along the way. But the goal really is to have plenty of time at the end to answer any questions that folks might have. So with that, I just want to remind folks who we are, and Charmaine already did a good job of setting this up. County Health Rankings and Roadmaps is a program of the University of Wisconsin Population Health Institute. And our mission at the Institute is really to accelerate capacity of communities to create equitable conditions for everyone to be healthy. And this mission is not that different from the mission that you all have in Bronx Health REACH. And we do this at County Health Rankings and Roadmaps by supporting community-led efforts, so people and places have what they need to thrive. And we do this in a number of ways. So today we'll primarily focus on kind of data and evidence and resources that we provide. And we do this primarily through our annual data release. And as Charmaine mentioned, the 2025 annual data release will likely be our last. Our funding from the Robert Wood Johnson Foundation will end. And although we are actively seeking alternative funding has not been secured. So one of the really kind of big and important things that we did this year was revise our model. And so I have the 2014 version of this model on the slide here. And this is what is kind of the backbone for kind of how we organize our work and think about our work. So this model, you might be familiar with it or have seen it in the past, was really foundational, over a decade ago in shaping our understanding that where we live, learn, work, and play influences our health. And really, the take-home message of this model was that health is more than healthcare. But at County Health Rankings and Roadmaps, we're part of a university and we have a culture that we're always investing in kind of learning and evolving. And so over the past decade, the evidence has continued to evolve. And as a result, we wanted to make sure that this model really was still reflective of the best evidence available. So one of the things that that really grounded us in the evolution of our model was in thinking about the structural determinants of health. So my colleagues at the Institute did a scan of the literature, engaged lots of partners and conversations, and came up with this definition of the structural determinants of health. Really simply put, if the social determinants of health are the conditions where we live, learn, work, and play, the structural determinants are the rules that are set and held by people who wield power that create those conditions. So what's really important here is that these conditions that shape how well and how long people live, they don't happen by chance, right? They are created. They are created through things like laws and policies and budgets. And those laws and policies and budgets are created by people, people that we elect, people that are in power. The other side of that is also true, right? So people in this room, you, me, we have power, and we have power to shift mindsets, worldviews, culture, norms. We have power to shape the decisions that elected officials make. And so the structural determinants of health really recognizes that health is shaped by more than just the social conditions, and that power and rules play a really foundational role in shaping the health of communities. So the goal of our model revision was really to elevate and animate the structural determinants of health. And I'll just note that like this is work that the Bronx has been doing for a while, right? Like this is, we've been engaged for several years. You've always engaged policymakers and decision makers, and you've been thinking about power and how to shift power. So this model in some ways really kind of catches up to some of the work that you all have been leading for some time. So I want to spend a couple minutes just introducing that new model. So this model, as I said, builds on really over 2 decades of scholarship and practice. But over the past few years in particular, we have been really deep in the literature and talking and listening to scholars and practitioners about how to evolve the model. So at a really high level, I want to walk through it. So in our society, health is often understood to be an individual experience, right? So like, how healthy am I? How healthy are you? In this new model, we really specify that our focus is on population health. So how healthy is your community? How healthy is our community? How healthy is our state? And what's really important is that it's not just about population health, right? It's about the distribution of health within a community. So there's variation. Even within the Bronx, there are people that might be doing well, and there are parts of the Bronx that might not be doing as well. The other thing that is really being elevated in population health and well-being is the well-being, right? So over the past, 10, 15 years, we've really seen an evolution in how we think about health, that it's more than just quality and length of life. And so we've introduced the concept of well-being to really reflect that shift. As we go down the model, you'll see that we've renamed health factors community conditions. And this is really calling us to really narrow in on what we mean here. So community conditions are where we live, learn, work, and play. These conditions include things like clinical care, housing and transportation, but we've also added things like climate. And we've seen, and I actually think New York has experienced this over the past week, the role that climate and climate change is playing in shaping the conditions where we live. So community conditions are really meant to be the social determinants of health. If we go further down the model, this is where some of the most significant changes have been made. So our new model names that societal rules. So these are both written through things like laws, policies, and budgets, and they're unwritten through things like worldviews, culture, and norms shape those conditions. Again, these conditions don't happen by chance. They are a result of rules. So these unwritten rules, like I mentioned, include things like worldviews, cultures, and norms. And by naming these and what shapes those conditions, we can better diagnose the role that power is playing in shaping these conditions. I'm going to share a video on this next slide that will kind of walk through it, and then I'm going to dig a little bit deeper into power specifically.
Well-funded, safe, affordable housing, well-funded schools, reliable transportation, good jobs, clean air. These are some of the building blocks of a healthy community. But what creates these conditions? Why do some communities have what they need to be healthy, while others do not? These conditions didn't appear by chance. What would we find if we looked at how they came to be? At the root is power. Those who have it create the laws, policies, the rules we live by, and determine who gets what they need to thrive. Those with power shape our laws and budgets, set our agendas, and influence our beliefs. But who determines the rules a society lives by? Who decides who gets resources and money? At the University of Wisconsin's Population Health Institute, we've created a new model of health. It helps us understand the forces behind the community conditions we see and how they're contributing to how long and how well people live. This includes looking at power, societal rules, community conditions, and population health and well-being. In doing so, we're exposing the layer beneath the community conditions we see. We can look deeper, unearth how decisions are being made, pinpoint the root causes of poor health, and build power so everyone can live long, healthy lives. Take a community that comes together, that organizes, and reclaims abandoned properties, turns them into affordable housing, creates green spaces, promotes jobs with fair pay, all of it leading to a healthier community. We're asking questions to understand the forces shaping our health. We hope you're asking those questions too. Together, we can make a difference. We can ensure everyone has what they need to thrive. Learn more at the County Health Rankings and Roadmaps website at countyhealthrankings.org.
All right, so that was a really kind of high-level video that reiterated some of the points that I was making in the setup of our model. I saw that there was a question in the chat about sharing the link, and I'm happy to do so. You can also go to countyhealthrankings.org, and the video is right on the homepage there. I want to talk a little bit more about power, and I know you all are thinking about power and have been working around power, and the whole agenda today is really focused on power. And there's a lot we can say and a lot we can dig into here. I think it's important to talk about power because in public health, we often don't like talking about it. Sometimes it can feel like if we talk about power or the idea of gaining power, it might feel like it might feel unethical, it might feel like we're trying to control. But power can be positive. And the first definition of power that I want to offer is one from MLK Jr. So Martin Luther King Jr. defined power as the ability to achieve a purpose. So whether or not it is good or bad depends on the purpose. So again, power is not good or bad inherently. It depends on the purpose. So if we're working to advance health equity, our purpose is good, I think, and our attitude needs to change. That in order to achieve health equity, we actually need to understand power better. In public health, though, and the work that we do, we can sometimes feel powerless, like we don't have the power or resources we need, that there are scarcity. And while that can be true, we're not completely powerless. And there are forms of power that we do have, and there are actions that we can take to build power. And one of the other definitions that I'll offer is from Manuel Pastor et al., which is a definition of community power. And community power is the ability of communities that are most impacted by structural inequity to develop, sustain, and grow an organized base of people who act together through democratic structures to set agendas, to shift public discourse, to influence who makes decisions, and to cultivate ongoing relationships of mutual accountability with decision makers that change systems and advance health equity. I wanted to offer these definitions, mostly just to make sure we are kind of grounded in a shared reality of what we mean by power, and to recognize that in order to do the work that we are trying to do, we cannot ignore power. The other thing that I just want to note before I get into a little bit more about some of the data around the Bronx specifically is that there's a relationship between societal rules and power. And it's reciprocal, right? So power is what is used to create and maintain those rules, whether it's a worldview, whether it's a policy, whether it's an institutional practice. But the rules also determine who has power. And so it's really important that we don't look at power in isolation of some of the ways that societal rules are kind of shaping who has power and how people in power are shaping those rules. So the 2025 annual data release was really oriented around our new model and introducing that model to the field. So we launched that video. We have a report that digs deeper into the model. You can find all of that at countyhealthrankings.org. But in addition to kind of releasing the report, we also updated county snapshots, and there are county snapshots that are organized around our model of health for nearly every county in the US. So because we introduced a new model of health in 2025, there were a number of significant changes that we needed to make across the website, which meant that we've remapped measures to their new home with their new model. We've also introduced some new measures. Some of those measures go into calculating summary measures, which I'll share with you in a bit. So there's some shifts in how things happen between 2024 and 2025. And we can talk about those in a second. But in total, every county has 90 total measures. In addition, there is data disaggregated by kind of race when it's available, and there are trend graphs over time. And then there's a subset of measures that are used to calculate those summary measures. I wanted to note that there's a few additional measures that we added this year. So we added a measure of functional limitations around disability. We added 2 measures related to social connectedness. So a measure of feelings of loneliness or lack of social and emotional support. We added a measure around access to libraries as being an important community resource that helps shape community conditions. We added a measure around access to parks. And then with the introduction of climate to our model, we introduced a measure around adverse climate events. One of the other kind of changes that we made last year, but I want to lead with, is kind of how we've shifted the way that we communicate and share kind of how counties fare relative to others within a state. So in this graphic, you're seeing the health, population health and well-being data for counties that make up New York State. So if you were to zoom in, there are 62 dots on this continuum, one for each county in the state. And they're put on a continuum from least healthy in the US to healthiest in the US. What you see here is that Bronx is 62 out of 62 counties in New York State. But what you'll also see is that it's below the national average, but it's not that far from the national average. And it's not it's by far not the least healthy in the nation. So we see that it's true that Bronx is ranked 62 out of 62 when it comes to population health and well-being outcomes. But when we look at New York State kind of as a whole and where Bronx is situated, it's actually not that far from the national average. And I want to kind of underscore kind of why this new view we think is stronger and helps communicate a little bit more specificity. So I want to have us travel for a second to New Mexico so we can make this point. So one of the things that we are excited about in this new view is that you can see where there's gaps really between counties. So for example, Los Alamos County fares better than the average county in New Mexico for population health and well-being, and better than the average county in the nation. So this county in our old kind of system would have been ranked first. But what this graphic shows is that there is a meaningful difference in health outcomes between Los Alamos compared to the second ranked county, Donna Ana. So Donna Ana County fares better than the average county in New Mexico for health outcomes and is better than the average county in the nation. But ultimately, those are two very different counties in terms of population health and well-being. And you can see that in the gap here. At the same time, you can see that the third ranked county in New Mexico actually isn't that different than the second ranked county. And so with this new view, you're able to better see the gaps between counties and how similar and different they actually are. And that's something that kind of those ordinal ranks, ranked 1, 2, 3, 62, doesn't communicate in the same way. The other thing that our new kind of view shows us is that you can better see kind of how those differences across state kind of translate into a map. So the colors assigned to differentiate the health groups are kind of at the bottom of this slide. So take a look at this legend for a minute. So that dark green represents counties that are among the healthiest in the nation, and that deep kind of gold color represents counties that are the least healthy in the US. When we look at New York State, you might see that there's no dark yellow or yellows actually on the map, which means that New York is a relatively healthy state. We recognize that the distribution of health doesn't stop at county boundaries or state boundaries. And so one of the other things that is really helpful about this new view is that we can now zoom out and kind of look at the distribution of health across the US. Again, this doesn't change how we're thinking about the Bronx's health relative to other counties in New York, but it does put it in more context. One of the things that Charmaine mentioned at the beginning of or in my introduction was that what this also allows us to do is identify counties that are experiencing similar health or similar community conditions as the county where you're at. So later this month, the Bronx is going to actually be convening a group of counties that are in a similar community conditions health group as them. And the goal of this is really to identify kind of do a shared analysis about how has power and societal rules shaped those conditions, and how can communities work together to better improve the health of where they live. All right, so I just gave a kind of a high-level overview of kind of the population health and well-being summary score of the Bronx. I'll dive into some specific measures in a couple slides. I also want to talk about the community conditions. So again, the community conditions are those social determinants of health. These are the things that shape that are determined by where you live, learn, work, and play. So it includes things like education and income and climate and housing. When we look at this view of health, we often think about this as kind of the predictor of future health. We see that Bronx is actually faring worse than the average in the county, and that there's actually a really meaningful gap between the Bronx and the next county kind of on this continuum. So unlike the health
people came out in trinkets. People came out in trinkets.
Oh, I'm sorry, I might have missed that.
I think somebody may be having a private conversation.
Okay.
Need to mute.
That sounds good.
Thank you.
So I think one of the important things, and we've had quite a few conversations with Charmaine and Eve and Mike and others about this is that so unlike that population health and well-being graphic where, the Bronx is, faring kind of below the national average, but isn't that far, we do see a pretty meaningful difference in community conditions. And this is also true when we look at the New York State map as a whole. So I want to kind of quickly walk through some areas of strength and areas to explore, and then I'll open it up for questions. So one of the things that we think is really important to our work is that we try to lead with an asset orientation. And so even though the Bronx might be ranked 62 in New York, the Bronx brings a lot of strengths. Some of them can be measured and some of them can't. But some of the things that we have on our snapshot that capture strengths are these measures here. So access to exercise opportunities is higher than New York State and higher than the national average. The uninsured rate is lower than the national average. Injury deaths and driving alone to work are all below the national average. This here is a graph of change over time around some of these areas of strengths, and this one is the uninsured. And this one I think is just really, striking and encouraging. So the percentage of people who are uninsured has been falling nationally and in New York for a long time. And New York has for a long time had a lower percentage of uninsured people compared to the nation. But the Bronx County in recent years has decreased this percentage faster than the nation and caught up to the state, which plateaued around 6%. So this is something that I think is worth noting and worth celebrating. This here is a change over time of preventable hospital stays. So in the Bronx County, there are 3,519 hospital stays per 100,000 people enrolled in Medicare that could have been prevented by outpatient treatment. So this is an area to explore because the preventable hospital stays is higher than New York State and is also higher than the United States value. These are hospital stays that could have been prevented if intervened kind of at a different level. Another area to explore is around unemployment. So in the Bronx County, 6.8% of people age 16 and older were unemployed, but seeking work. And this is higher than both the New York and the US state value. One thing to note here about kind of unemployment, so unemployment fits into our model around kind of the social and economic factors that that determine community conditions. When our team of analysts dug deeper into what's really driving the Bronx's community condition score, the social and economic conditions are one of the primary drivers of what's positioning the Bronx the way it is. So this includes things like unemployment, education, income, and that's so different from kind of the physical environment or health infrastructure. Children in poverty is another example of something that's really driving Bronx's kind of position in that community conditions continuum. So in Bronx County, 36% of children are living in poverty. And again, this is higher than both New York State and the United States, which is hovering around between 15 and 20%. Another example that I'll offer that fits into that social and economic factor is the cost of childcare. So in the Bronx County, the average household spent 65% of its income on childcare for families that have two children. We don't have a trend graph of this over time, but this is compared to 38% for the state. So 38% of someone's income anywhere else in the state is going towards childcare for two kids, where it's 65% in the Bronx. And that's much higher than the national, which is 28%. When we look at housing, we see that 39% of households experience at least one of the following housing problems, which include overcrowding, high housing costs, lack of kitchen facilities, or lack of plumbing facilities. And this is compared to 23% for the state and 17% for the nation. And then lastly, another kind of area to note or to explore is around income inequality. So in the Bronx, households with higher incomes had incomes that were 7.3 times that of households with lower incomes. And again, this is compared to 5.8 for the state and 4.9% nationally. So what this means is that there's greater inequality between earnings within households that live within the Bronx. There's a greater inequity within the Bronx County itself. So I wanted to bring back the model here before we kind of close things out. So I shared kind of the summary measure around population health and well-being and how the Bronx fares. I talked about the community conditions summary measure, right? So how well, or that the community conditions, so how where we live, learn, work, and play shapes where we live. You'll notice that I didn't talk about societal rules and power. And this is a question that I have for you all. So if we were to continue to be funded, this is the area that we would have continued to build out in the years to come. But I don't think you actually need to wait for us to help kind of think about what measures or how we might measure societal rules and power. So I'd love to know in the discussion, kind of what are some of the laws, the policies, the budgets, the worldviews, cultures, and norms that are shaping the conditions of Bronx County? And how have those societal rules come to be? And who was holding power to shape them? So that'll be an important question that I'd love to hear some insight on. The other thing I wanted to note is that in addition to providing data, we have a resource called What Works for Health. And this is a database of evidence-informed policies and programs. And this year we added a strategy around community organizing to really get at this idea of power. So how do we build power within communities? And so our analysts have summarized the evidence and assigned it a rating of expert opinion. One thing I'll note is that I know later in the agenda there's a discussion around participatory budgeting, and we have a participatory budgeting strategy in What Works for Health as well. And participatory budgeting is one strategy to try to redistribute power within community. One of the other things I wanted to note before we break for discussion or questions is around, we've introduced a new kind of tool to What Works for Health called EVI, which is short for evidence. So this is a tool where you can go in and ask questions, and it'll direct you to strategies within the What Works for Health database. So this is an AI tool, but it's only based on kind of what our team of analysts who are highly trained have kind of summarized and added to the What Works for Health database. So if you haven't checked that out yet, I'd encourage you to do so. This is the last slide. There's lots of ways to stay in touch. So even though our funding is ending, we still have at least a year of work ahead of us. So please sign up for our newsletter to stay engaged or up to date. You can follow us on X and Facebook and LinkedIn. And we have an amazing kind of monthly webinar series that you would learn about through the newsletter that really highlights the ways that communities are translating our model into action.